I've diagnosed metabolic disease, prediabetes, even full-blown diabetes in over 1,000 people when their doctor had no clue. Now, why does that matter? How do you know you don't have it? Take a look at the numbers. They're really clear. Between 7 and 12% of us don't have a problem. The rest of us do. So are you really feeling that lucky, or have you just been in a little bit of denial like most of us? Here's the opportunity. You can take the risk associated with this problem right off the table. 90% of the people that have this problem don't know it. And again, how do you know that you're not part of that 90%? You don't have to be guessing. You don't have to be worried. You can find out. In this video, I'm going to show you exactly how I test for prediabetes, diabetes, metabolic disease. We're going to go into your metabolism and show you what your body's actually doing. We're not going to be guessing about how your body metabolizes carbs. We're going to show you. We'll show you the exact tests and how to interpret it. Well, maybe you're asking, okay, that's all well and good, but why does it even matter if I have diabetes? I know that's bad. It just raises my blood sugar. Diabetes is really the number one cause of heart attack, stroke, and those two are the number one and number three cause of death. It's the number one cause of Alzheimer's. It's the number one cause of kidney failure, blindness, and for you men, erectile dysfunction. My name is Ford Brewer. I'm a physician, and I came back out of retirement to help people understand this problem. By the end of this video, you'll understand exactly how to find out whether you have risk too. Now, let me introduce you to a test that can find up to 90% of those cases. And obviously, if you use it, you've got a 90% probability of being able to find it. You go to the lab, having fasted for about 8 hours, at least 8 hours. The lab tech will draw the blood, and after that, we'll give you a drink called glucola. It's syrupy sweet, and it's going to have 75 or 100 grams of pure glucose in that water. I know for a lot of people, especially if you don't like syrupy sweet tastes, that sounds icky, terrible. Unfortunately, that is the best way to measure this. It's a standardized process, and now you can know how you compare to other people in terms of your body and its metabolism, its ability to manage and digest and metabolize glucose. For those who don't eat carbs, again, that sweetness can be a little bit sickening. For most people who are still dealing with addiction to carbs and junk food, it might be the equivalent of a McDonald's meal. It might make you fall off the wagon and go down that addiction highway again. After drinking the glucola, you'll have to wait for an hour. And at that point, you'll have your blood drawn again. Some protocols involve drawing blood at half an hour. The test is not over yet, even at the 1 hour mark. You have to wait another hour and then get your blood drawn a third time. There's an option to get it done at the 30-minute mark, as we said. And again, that's just an option. That helps us more information. It's more helpful. This test that we're talking about is called the oral glucose tolerance test. Now, you might be thinking, should I really go through all of that? That's a hassle. You got to get up, you got to fast for 8 hours, you got to get up, you got to go to the lab, and you got at least 2 hours there in getting your blood drawn. I'm sorry to tell you, but yes, this test is so good. It's the test used to diagnose diabetes. It's the one that you need to do. And we'll tell you what your other options are. If you're thinking, oh, I can get a fasting glucose, or I can get a hemoglobin A1C, or the academic types are thinking, I can get a HOMA-IR. Just hang in there. We'll talk to you about the actual statistics for those studies. Did you ever wonder why pregnant women, even still today, are getting this test? They're looking to diagnose gestational diabetes, the diabetes of pregnancy. And by the way, if you have had that and you did have a problem when you were pregnant, your risk of having diabetes as you age is much, much higher. So this is not just to protect your baby, it's to protect you as well. Why aren't we using this test for every adult? It's a headache. I understand. I get it. Nobody wants to sit down for 2 hours at the lab after having fasted for 8 hours and get stuck multiple times with a needle. That's just not fun. But when you realize that the other tests that doctors use, like fasting glucose and A1C, here's the thing. They miss up to 70% of cases. Ever wonder why 90% of people with prediabetes, insulin resistance, diabetes don't know it? This is one of the major reasons. The tests most often used, A1C and especially fasting glucose, miss more cases than they pick up. And this is not just me saying this. This is even the American Diabetes Association in a white paper on diabetes testing. The American Association of Clinical Endocrinologists, the AACE, has said, don't use A1C to diagnose this issue. So after you begin to understand the importance of this disease process and the fact that most testing that's being used today is just not working, you do like me. You bite the bullet and you go get the fasting glucose, the 1 hour. You get the whole oral glucose tolerance test. It was March of 2019 I took this test, and in fact, I've taken it probably over a dozen times. But we'll go over one of the tests that I did in March of 2019. I was 61 years old, and I had found out that I had arterial plaque about 3 or 4 years earlier, fairly recently. Let's take a look at my results. My fasting glucose was 86. That's a good number. And here's a little tidbit that you might not know. So when you ask doctors, most of them will say, oh, I use A1C to diagnose diabetes. The reality, most diabetes that has been picked up was actually picked up from a fasting glucose that happened to be done for something else, like a surgery. Then the fasting glucose came back over 125. The doctor realized this patient has diabetes. But again, that's still missing so many more cases than it picks up. And if you have it, you need to know it because you can take the risk off the table. That's what this whole discussion is about. You can remove the major risk for heart attack, stroke, blindness, kidney disease, and erectile dysfunction. You just got to know about it. That's why it's so important. So back to my test, March of 2019. 1 hour after I drank the glucola, my blood sugar spiked to 183. And at the 2 hour mark, it had come down, but it still wasn't below 100 yet. It was still 114. Now, let's talk about how to interpret these results. So here's where I disagree with some of the guidelines that are out there. For example, if you follow the ADA guidelines, the American Diabetes Guidelines, there are only two numbers to look at, the fasting and the 2 hour. The fasting glucose, if it's over 125, they agree, you've got diabetes. That's their criteria. If your fasting glucose is between 100 and 125, the ADA will say you got prediabetes. But if you reach 200 or more in the 2 hour measurement, that's diabetes as well. Again, according to the ADA. A 2 hour value between 140 and 199 indicates that's just prediabetes. Now, here's my problem, my beef with this approach. If you wait for your blood sugar to reach those values at the 2 hour mark, 140 or worse, 200, you're wasting precious time when you could have been taking this risk off the table. You could have avoided damage to your eyes. Again, the number one cause of blindness, retinal damage due to diabetes, damage to your heart, to your brain, to your erectile mechanisms, to your kidneys. Insulin resistance really is silent, and you're going to miss the signs until it's too late. You can have very high insulin levels that can still help you manage your glucose and avoid the 2 hour glucose peak. Now, that's something to be aware of. So you end up in the same place, and after all that effort, you end up with the conclusion that you're fine because your 2 hour glucose didn't peak over 200. If your doctor does some tests on you and says, hey, you've got a touch of sugar, I advise that you be afraid. Be very afraid. But not so afraid that you have to get emotional about it. Take it seriously, more seriously than your doctor. Read up on this stuff, and you can take the risk off the table. Now, that probably could have been the case with my results. My 2-hour glucose was 114. Most doctors looking at that would have said, oh, you're fine. They wouldn't have even said you got a touch of sugar. But if you see my 1-hour glucose, it went as high as 183. That's 17 points away from full diabetes. So if you have a healthy metabolism, your glucose should never go over 140. Never over 140. And why is that? Well, anytime your glucose goes that high, a couple of things are happening. First, you're causing damage to the lining of your artery wall. And I'm at the level of diabetes now where it often goes over that 140 if I do any kind of carb vacation or cheat. But I don't let it stay there. I manage my blood sugar with diet mostly. I've cut the vast majority of my carbs out of my diet, also with exercise, but that's a different issue. Let's go back to what happens if your blood sugar goes over 140. You do damage to the artery wall, and high levels of glucose cause cardiovascular inflammation. Second, high levels of glucose cause a rise in insulin levels. Insulin levels also damage the lining of the artery wall. We've seen that before, and you may have heard some technical terms, hyperinsulinemia, meaning high levels of insulin. And it's been shown, those high levels of insulin, even if you're not finding or seeing high levels of blood sugar, they cause cardiovascular inflammation as well. Now, I'm not saying that single peaks are a problem. As I mentioned, I have those occasionally myself. But high levels of glucose, hour after hour, day after day, cause you to have a heart attack, a stroke, blindness, kidney disease, erectile dysfunction. It ruins your arteries. So don't let that happen. The peaks are one of those hidden signs of insulin resistance. Your body is no longer able to manage glucose like it did when you were younger and healthier. And it's unable to avoid going that high. The worst part is this. You don't feel anything. Again, until it's too late, you've got tissue damage to your arteries, your eyes. Again, you've heard me already. That's why I prefer to follow the approach recommended by the CDC. Now, I've got plenty of arguments with CDC. That's not the point here. And whether you like the CDC or not, or have political problems with it, that's not the point either. The point is, which definition of diabetes do you want to use to manage your risk, to take your risk off the table? So the definition that they use for diagnosis is, if during your oral glucose tolerance test at any time your glucose reaches over 140, you have prediabetes. If it reaches 200 or more at any time, that's full diabetes. Now, if you don't like being labeled as pre-diabetic or diabetic, that's fine. That's not the point here. Labeling and who you share information with is your business, not mine or anybody else's. Just don't wait until it's too late to find out that you've got a problem. If you wait that long, your body might already have so much damage, it's going to be impossible to reverse. But let's go back and think of a different way. What if you ace that OGTT? Does that mean you're totally off the hook? Well, think about it. You might not have prediabetes or diabetes, but you might still be having a problem. You remember we mentioned a few minutes ago the problem of having elevated insulin, but not elevated glucose. Your body might be able to lower your blood glucose fast enough, but how much insulin is needed, is required for your body to do that? If you're having to push way too much insulin, that's just part of that insulin resistance problem. It's that thing, that geeky term I talked about, hyperinsulinemia, in the face of normal glucose. Now, luckily, this is not the worst outcome, but it means that you're catching the problem early so you can deal with it before you have so much tissue damage. Here's how you test for this. It's basically the same process as the OGTT, oral glucose tolerance test. But instead of measuring glucose alone, you measure your insulin levels as well. You get an insulin level when you're fasting, 1 hour after the glucola, and 2 hours after the glucola. This is called the insulin response test, or insulin response to glucose. We routinely do an oral glucose tolerance test with an IR, or insulin response. It's very, very similar to what some people have called the Kraft Insulin Survey. In fact, the only difference between the OGTT and insulin response and the Kraft Insulin Survey is a couple of things. You get a couple of more blood draws with the Kraft Insulin Survey, and instead of using 75 grams of glucose, you use 100. These tests give you so much information about your health. Maybe not so much your health now, but your health 5, 10, 15 years, 20 years down the road. It's a great preventive test. Optimal levels for insulin response should be 5 international units or less at fasting. 5. 50 international units at the 1-hour mark and 40 international units at the 2-hour mark. These are low numbers compared to what a lot of people are walking around with. Interpretations go beyond just the values. There are different phenomena that can be found in insulin resistance. Pardon the use of the term phenomena. There are a lot of things that you can learn by looking at the results of this test. For example, a very low level at 1 hour, followed by a very high level at the 2-hour mark. That means that your body just can't release enough insulin on time. And when it does, it requires a lot of insulin to manage your glucose. That's one feature of insulin resistance. In fact, we call that loss of first phase. You see, the pancreas can actually store insulin, and usually with a healthy pancreas, you can get an immediate or 30-minute release. Somewhere between immediate and 30 minutes, you get a good release of insulin. But if you're already insulin resistant and your pancreas is having to work harder, sometimes you begin to lose that stored insulin or first phase response. Now, as you see, there's a lot you can tell from this testing. Unfortunate fact is we're one of the very few, in fact rare, medical services that you can find that's going to prescribe, use, and interpret this test. We have found hundreds of cases of insulin resistance without prediabetes or diabetes by the definitions. So think twice. Think about this as something for your health management for your future. Finding the problem on time is critical. I have one more caveat to add to the test. If you look at those ADA guidelines, they suggest eating 150 grams of carbs one day prior to the test. That's called carb loading. The idea is that if you're on a low-carb diet, you won't have enough insulin stored in your pancreas to put into your bloodstream. In other words, you'll have an artificial loss of first phase. So when challenged with glucose during the test, your body won't be able to manage it. Well, I can tell you. Let me finish with the theory, and then we'll talk about the actual reality. The theory is that this results in high levels of glucose and therefore a wrong or inaccurate or false diagnosis of prediabetes or diabetes. But the bottom line is it's just not true. When you go back and you look at the studies that have been done, well, the most recent were quite a few years ago, published in the New England Journal. They did not indicate that this was a problem. I can tell you from doing these tests all day, every day, it's not a problem. There's not enough recent research about this. It's sort of an urban myth that you'll hear when you're looking around on the internet. We've seen dozens of cases of people doing the OGTT with and without carb loading. Let me clarify and correct that. Hundreds of cases of people doing the OGTT with and without carb loading. And I can tell you, we just don't see a significant difference. Actually, for somebody who's on a low-carb diet, eating carbs just before the test might not be a good idea. I have even seen patients who decline the test because they just don't want that much glucose in their bodies anymore, and they're not going to be eating that much glucose anymore, and they're afraid they're going to fall off the wagon and get back into that sugar or sweets addiction. And I have to tell you, I respect that. It's okay, too. I still encourage people to consider the test at least once. It's important to know how severe your problem is. And we are not going to know that unless you actually do some testing. A continual glucose monitor, continuous CGM, like Libre or Dexcom 6 or 7, or some of the others that are coming out, can help you get a pretty good gauge. And again, what we want to know is how healthy you are in this space. The oral glucose tolerance test with insulin response is the #1 test for finding metabolic disease. One of the major challenges here is the labs, the actual labs that are hiring the people that draw the blood. For the most part, we use Quest and sometimes LabCorp. And let me tell you, sometimes the lab techs just don't understand this test. And that's unfortunate, and it can be very, very frustrating. The technicians get confused sometimes because they just haven't done the test that much. So we'll see errors, and it's frustrating, and it's a big challenge. Some of the best lab techs that I know, at least one of the best that I knew, made that error on me on my blood draw. I'm not going to go down that bunny hole, but it's frustrating when you spend the time to do this test and it's done wrong. One of the major reasons that most doctors won't prescribe it and patients won't do it is nobody's done it before, they don't understand it, and quite often they'll see cases where there was an error in terms of managing it, doing it, or interpreting it. It takes time and effort. This is not easy stuff. But if you don't want to go to your doctor and get an order and deal with Quest, there's an alternative. You can do like an at-home version of this test. In fact, I've done that in videos in the past. I did what I called my Mott's applesauce oral glucose tolerance test. I took enough Mott's to get over 100 grams of glucose, and I fasted. So I fasted, did my test with a finger stick, waited an hour, got another finger stick test, and then waited 2 hours. So here's what you do. You fast for 8 hours, just like in the regular test. Get your blood glucose with a finger stick glucometer. Write that down. Then get the 75 grams of glucose from something like Mott's applesauce or something similar. And yes, I know it's not the best option, but we want to have something as close to 75 grams as possible. If you're thinking, wait a minute, I thought he said 100. Again, there are protocols that use 75 and protocols that use 100. We'll be happy to help you clarify either one. Your blood sugar should not go over 140 after either 75 or 100 grams. Measure your glucose again at 30 minutes, 1 hour, and 2 hours after eating the Mott's applesauce or whatever glucose source you're going to use. And if you're thinking, wait a minute, applesauce has fructose in it, and that's not going to show so much. Although you may have some technical point there, one of the reasons that I chose that specific applesauce was because it had glucose added to it. And it did show my blood sugars going over 200. So adults think that applesauce is healthy. For them and for others, not so fast. A lot of applesauce has a lot of glucose in it. And even if it were pure applesauce, you still need to try it. You'll see your blood sugars go up. Now, this is not as exact as the lab result. It's what we call a good proxy. It helps you begin to start getting estimates. And that's what you want to know. Unfortunately, there's not a good fingerstick device to measure insulin. So you can't go into a home version of the insulin response. That's something at this point that you can only get at the lab. You keep hearing rumors, and I heard one most recently from another YouTube creator in my space who really looks hard at insulin. But I just haven't seen it ready yet for prime time. A home insulin test. Now, if you don't want to be sticking your finger multiple times, there's still another option. You remember I mentioned CGM, continuous glucose monitoring? Well, you can use a device. Remember I mentioned the two most common ones are Freestyle Libre or Dexcom. You place the patch and you read the numbers with your cell phone. But it's still not as accurate as, usually it's not as accurate as the finger stick, let alone as accurate as a lab. But I'd be very careful not to use a CGM for diagnosis of diabetes, for example. If you start seeing patterns that indicate your blood sugars are going too high, over 140, that's when I would consider. That's what I would do at that point if I were you. I'd say, I've got some risk here that I didn't know about, And I think it's worth a half day for me to go to the lab and get a real OGTT and get an insulin response while you're at it. If your glucose on the CGM goes up over 200, again, I would definitely go get a real OGTT and insulin response from a real lab. Now, we've covered a lot. There's still a couple of tests I'd like to go over with you. If the OGTT with insulin response is not an option for you, there still are other alternatives. They're not as good, but they can help. I'll list them for you, and then we'll discuss those tests. One is fasting glucose. Another is A1C. A third one is called HOMA-IR. And one last mystery test. Let's go to the first test. Fasting glucose is one of the first things to review. And as I mentioned, in reality, if you go up and ask a typical doctor today, most doctors will say, ask them, how do you diagnose diabetes and prediabetes? Most of them will say with hemoglobin A1C. And that's not really what happens. Most diabetes that is discovered is usually discovered through this test, fasting glucose. The criteria for diabetes is at least 2 samples reaching 126 or more. For prediabetes, it's 100 to 125. So if you've ever had 100 or more and you're told, as I said, well, you got a touch of sugar. As I said, be afraid. Be afraid enough to know it's not fear we're talking about here. It's an opportunity for you to protect your health. Take this more seriously than your doctor's taking it. You're beyond insulin resistance. You have prediabetes. This is your opportunity to take action. The problem is, even with this clear layout, fasting glucose misses 50% of cases. So if you had a fasting glucose that showed this, you're actually lucky. You could have still had this problem and not even known it because the glucose missed it. It's not to say that this doesn't detect insulin resistance before prediabetes. It's just to say that it misses half of them. Now, remember the second test? I mentioned it a few times, A1C, hemoglobin A1C. Hemoglobin A1C is actually what we would call an AGE. And I don't mean age getting older. I mean an advanced glycation end product. What does that mean? It's where glucose binds to the protein. And when it does that, that bond doesn't break apart. So you get a permanent bonding of glucose to proteins. Those can damage things like the kidneys and cause high blood pressure. But they're also a good way for us to tell if you have any risk for prediabetes. Particles of sugar, when they're too high in your blood, attach to the protein in red blood cells. That protein is called hemoglobin. And that attachment is called glycation. Actually, sort of like turning the hemoglobin or those cells in your blood into plastic. It's denaturing that protein. Red blood cells live for about 90 days, and that's why A1C is used as a reflection for blood glucose levels for the last 3 months. When you have an A1C of 6.5% or higher, most people recognize that as full diabetes. Prediabetes would be between 5.7 and 6.4%. But again, I can tell you from doing this, for most people, by the time you get to 5.7, you're at a place where you're forming plaque. You're irritating the lining of your artery walls, and therefore you're doing tissue damage. So that A1C may sound like the test we need, right? High glucose over, it should be flawless. But unfortunately, it isn't. It misses up to 70% of cases. 70%. It misses even more cases than fasting glucose. Why is that? Other blood issues can cause problems like anemia. Changes in your blood cells, they can reflect the results. You have to be careful using A1C. Guess what? Now you're beginning to see why we're missing 90% of cases of metabolic disease, prediabetes, diabetes. Even when we're testing for them, the tests are missing it. So let's go to the third one, HOMA-IR. We used to get a lot of comments from more academic types saying, HOMA-IR is the way to do it. You don't have to worry about all this other stuff. That's not true. HOMA-IR stands for Homeostasis Model Assessment of Insulin Resistance. It's calculated with this formula right here. Depending on the reference you review, some references will mention 1.9 for early insulin resistance and up to 3.2 for frank or significant or full-blown insulin resistance diabetes. But standardizing the results, it's been a big problem. And there's a major problem with the formula. If you take a closer look, it's based on fasting glucose and fasting insulin. That means it does not reflect a response to glucose intake. This is a moving picture. It's not a static still shot. So it misses a lot of cases, at least, very least 15%. So, yes, I would agree. It's still a good option, better than fasting glucose alone or A1C alone, because it actually involves measuring both insulin and glucose, but it's not the best test. Now, you remember I mentioned that last mystery test? This test uses biomarkers from lipid panels to identify insulin resistance. Get ready because it's going to get a little bit geeky. Sorry about it, but if you want to know about that test, you got to be patient with us for a second. These right here on the screen are called lipoproteins. Lipoproteins are like little submarines. They transport cholesterol and triglycerides within your bloodstream. But why, you might ask? Well, that's because fat doesn't mix with water. So something's got to carry those fats. Cholesterol and triglycerides are fats. Fats need something to float around in the body because fats are fats and are oils, and the bloodstream is over 95% water. So let's think about this. You've got a couple of famous particles. HDL is one of them. That contains what people call the good cholesterol. LDL is the other one. That contains what people call the bad cholesterol. The cholesterol is the same. It's just which particle it's being carried in. And even then, HDL is not so bad, and not so good, and LDL is not so bad. Now, it's basically the same cholesterol, a different submarine, different particle. The ones I want you to look at, though, are the ones right here. These are called remnant cholesterol. They're bigger particles. They carry a lot more triglycerides. When fat, that is triglycerides, and cholesterol is absorbed from the intestines or is produced by the liver, it gets transported by these particles. It's packaged in particles called chylomicrons. As you can see, the content of these chylomicrons is mostly triglycerides. Chylomicrons just don't last long in the bloodstream. We want those to get metabolized, to drop off their triglycerides, and for that triglyceride to get burned. The sole purpose is to deliver triglycerides to be used as energy or stored in fat tissue. That's the purpose for remnant cholesterol, or chylomicrons. As they drop the triglycerides, the chylomicrons shrink in size. They have to. At first, they were carrying a lot of triglyceride. As they drop that off, they shrink and they become something else. Again, here comes some of the geeky part. They become VLDL, very low density lipoproteins, and then IDL, intermediate density lipoproteins, as they continue to drop off more triglyceride and get smaller and smaller. Now, different from LDL and HDL, these particles carry mostly triglycerides. Remember that. Here's the problem. A lot of triglycerides leads to inflammation and obesity. In fact, that's part of one of those unholy or dangerous spirals. Increased problems burning triglycerides leads to inflammation, obesity. Obesity creates more hormones like resistin, which keeps us even more so from burning our triglycerides. And again, we go in that vicious spiral down into poor health, towards a heart attack, a stroke, blindness, kidney disease, erectile dysfunction. Now, can you tell me which macronutrient, large nutrient and there's only 3, proteins, fats, and carbs. Which of these three causes elevated triglycerides? In our society, high triglycerides are an immediate result of eating too much carbohydrates or sugar. These are transformed into triglycerides by the liver and then packaged into chylomicrons. So this test, it's called the LPIR score. That's the big mystery test. It stands for Lipoprotein Insulin Resistance Index. The LPIR score measures the impact of insulin resistance on the amount and size of these particles. The measurement of the sizes of these different particles is called lipid fractionation. LPIR uses the fractionation to come up with a number to establish insulin resistance. A score of 45 or more reflects insulin resistance. But the problem with this test is it's based on a more indirect measurement of insulin resistance. So it can miss up to 25% of cases. Again, you'll hear a lot of doctors refer to the LPIR, and they'll say, why do you have to do all that OGTT and insulin response? Because you miss more cases when you do that. That's why. It also requires a 12-hour fast, not just 8 hours, just like basic lipid panel testing. It's still a good option. We can use it. We use it a lot. But again, as we've discussed, there are better options. This disease kills a lot of people. A whole lot of people just died. And that's terrible. And it gets worse. You might be dealing with it right now yourself. You remember Lucy and Ethel in that famous chocolate factory scene from I Love Lucy? Insulin resistance is sort of like when the chocolates start coming a little too fast, but they're managing to keep up just barely. And in your body, what that means is your insulin receptors have slowed down. So when sugar comes in, you can't quite manage it as well, but you're keeping up. Prediabetes is when that belt speeds up and they're starting to stuff chocolates in their mouth and everywhere else to try to keep up. And diabetes, that's when the whole thing just goes haywire. And the chocolates are piling up everywhere. The sugar's piling up. And guess what? It piles up in your body fat. It gets turned into fat. It piles up, making more and more body fat under your skin. Body fats that you transport in your bloodstream. And body fat that you deposit around your abdominal organs, your liver. Thankfully, you are watching this video now, so you're not included in the statistics of people that aren't listening. But now you need to know how I check for plaque. You can find that out in this video right here.